They're also up there for you underneath the participants, and above your chat, you'll see a little emoticon, and you can open that up and pick an emoticon. Let me know if you're sleeping or if you're excited or happy, whatever you want to choose in there. We're not going to do any polling today, so that's out, but there will be a survey at the end that's going to pop out when you log out. So please fill this out. We want to know what you would like for upcoming sessions for the future. And with that, again, is Michael, are you on the line? Okay. I hope he hasn't forgotten us. So what I can do is Michael Gardam was going to join us today. Now, Michael is the national lead for the National Research Project that started, I guess, about a year ago in Positive Deviance. I can probably give a bit of an intro. I am one of the coaches on the national call, and so there's a handful of us that provide mentoring to the 6 BC teams that actually are our stars in the National Research Project. So there are several hospitals from Toronto. There was one in Winnipeg. They had to drop out. And there's 2 here in BC. Michael, have you joined the session yet? Okay. So maybe what I'll do is just give you a bit of background to Positive Deviance. Is there anyone out there that has been introduced to the concept of Positive Deviance? Put your hands up, please, if you have. So Clarissa, Chris, okay, so there's a few of you that know. That's great. Yeah, and of course our teams for sure. Okay. So I guess in Michael's absence, I guess I'll just jump in. So Positive Deviance, actually, the concept came out of a lady called Marian Zaitlin, who did some initial work with Positive Deviance and undernourished kids through Tufts University in the States. She just basically came up with the idea that Positive Deviance is... Michael, are you joining the call yet? No? Okay, I'll keep going. Sorry about that, you guys. So Marian Zaitlin just basically found these pockets of nourished kids in the face of all odds, and that was basically the end of her research project. What happened then was in the early 1990s, the Sternen couple, who were working with Save the Children Foundation, came into the picture behind Tufts University. They were actually seconded into the country of Vietnam by the government to look at reducing malnourished kids in their country. They had 6 months to do it, and partly that was because the American war had just been on. They were not thrilled with Americans, and also for the other fact that nothing had ever worked before. So there wasn't a lot of faith in what was going on in the system. So the Stearns said, well, I don't really know what we're going to do, but we've had a little bit of success with this nutrition research paper, so let's see if we can make some change. So they actually took an interpreter and went into the villages, and they started studying and looking at what was going on. And they started to ask the villagers if there was anyone, any families within the villages that were actually doing really, really, really well. And the villagers said, yes, there are some people that are doing really well. And so they started to watch what was going on with these families. So they started to study what the families were doing and observe at meal times at what they were doing with these kids. So after watching, they found that they were doing these sort of deviant behaviors. So these moms and dads were feeding their kids more often during the day. They were feeding them things that were culturally not acceptable to the most people. And they were asking the dads, the grandmas and the grandpas to watch these kids and feed them more often during the day in the face of having diarrhea and a lot of the nutritional problems that they had. And so they found that these kids were eating crabs and shrimps and taro tops and things that were not usually done by other people. So They invited the other villagers to come, and they actually learned from the people that were the positive deviants. So the Sternans did nothing. They just allowed the villagers to teach the other village moms and dads what was doing really well. After some further research and coming back 4 years later, they were so successful that they actually managed to sustain it and spread it to other families and further generations down the line. So based on that, they took positive deviance around to insolvable problems around the world, such as genital cutting in Egypt. They took it to Pashtuns in Pakistan, where they had a huge infant mortality rate, and, of course, into MRSA in the States and some South American countries. So that's kind of where positive deviance came from. Positive deviance research in the States with MRSA and hand washing proved very, very, very successful. And so Michael brought it here into Canada. They started with the University Health Network in Toronto about 6 months, I would say, prior to starting the national research project with the 6 beta sites in Canada last fall. So that's the background to positive deviance. And I'm going to just suggest a couple of resources for you. I just finished reading the book called The Power of Positive Deviance, and I have to say, if you know nothing about positive deviance, or you've been working with positive deviance and you want to deepen your awareness, please read the book. It is an absolutely amazing read, and it takes you into a really deep understanding of positive deviance, and it's certainly into a great introduction. The other book that it's a really good follow-up to that, even though it doesn't say that it's positive deviance outright, this guy talks about it through the book, and his name is Gordon Mackenzie. He worked at Hallmark Cards for 30 years, where he inspired his colleagues to dream, dare, and be creative, and to resist the constraints that normal organizations put around you when you sign up on the dotted line and become an employee. So Orbiting the Giant Hairball by Gordon Mackenzie. So that's a brief introduction to positive deviance. This is a slide showing the Positive Deviance website. If you want to know more, you can go to positivedeviance.ca, or positivedeviance.org is the website that the Sternans have made, and it's a fabulous website with lots of resources and insights and stories from there. We will love to have a conversation with you towards the end of the presentation, so we're going to leave about 15 minutes at the end. So as we're talking, think about your insights or questions for the group or individuals. And with that, I think I'm going to hand the ball over to the Kelowna team. So I'm just going to get Sherry and unmute Sherry and Missy.
And Missy's in the office with me.
Perfect. So you guys are unmuted now, and I'm just going to make you guys presenters. And I'll pass the ball to you, and there's your presentation. So if you want to move your slides forward, you guys, up on the very top right, you'll see little arrows. You can actually use those to go forward to the next page. And I'll let you introduce yourselves. So this is the Kelowna Positive Deviance team. Go ahead.
Hi, my name's Sherry Belanger, and I have Missy Blackburn and Holly Morgan here with me. There's 2 other members of our core team that aren't here right now, but we're from Kelowna, and we're about a year into our Positive Deviance project. And when we started our project, our main thing that we did was improv, and but we've been having weekly meetings with our core team. We've been doing a lot of improv. We've been doing a lot of discovery and action dialogues. We've had coach and all members calls. We've had, my screen's going back. We've had some open houses. We've done a lot of things. So my slides are just going to go through some of the activities we've done, some of the challenges we've come up against, and some of the progresses we've made along the way. So that's just a picture of our core team right there. I'm Sherry. I don't know. It keeps going back. Yeah.
Oh, that's weird. Are you able to advance your slides on your own, Sherry?
Well, I'm advancing them, but they keep going back.
Weird.
Okay. So my name is Sherry. I'm a patient care coordinator on a medical unit. It's an acute medical unit. Missy, that's also here today, works with infection control. And Holly, the other member that's here today, works for the QI department. So Lisa is my manager. She's a manager for my unit. She's also on our core team, and Jackie is a housekeeping supervisor. So these were the initial members, and we've been together for about a year now. Our coach is Keith McCandless from Seattle, and he's been out for a couple of visits. And he usually joins us by phone for our teleconference calls, too. So he's been an excellent resource, and if we have any issues or problems, we know we can always call him or email him, and he can help us out. So when we very first went to Toronto and learned about PD, because we kind of went into this blind, we didn't really know what it was all about. We were interested because we were having some issues with hand washing and the spread of infection. We were really interested in stopping the transmission of superbugs. And when we went to Toronto, they did some improv there, and we were really excited about it. I've been at KGH for 25 years now, and I've never seen anything like improv, and I thought it would be something new that we could introduce to the hospital and that people would pay attention to and that we may get people excited about. And the pictures here is our very, very first improv that we did. We kind of went in blind. We had never done it before, so we did it with the patient care coordinators and the educators because we kind of felt comfortable with them, and we knew they would give us some good feedback. And what we found is all we were really nervous and we didn't quite know what we were doing. It went really well, and as you can see from the bottom picture here, people paid attention. They were actually laughing. There was a lot of engagement. We knew then that we would use a lot of improv and move it on out to different areas. So what we've done for our improvs is we go all over the hospital. Our main focus was just going to be on 4 East, but we found we've moved out everywhere. What we do is when we go to an area, we try and get some participants from the group that we're going to and see if we can either have a discovery and action dialogue with them, have some discussions with them, and figure out what their issues are in their area, if they have any issues. And we also try and pull some of their staff out to help us with that. And then we pick our scenes, we pick our topic, we pick the idea that we want to portray in the improv, and then we take our group of actors and we go and do an improv. So we've done a couple here. We've done a refrigerator, and that's when we had a discussion with a bunch of staff, and they said there's always issues because patients are supposed to be on isolation and they don't follow the proper protocol, and they're roaming the wards and they're getting into the fridge and they're touching everything. So we did a whole improv around that scene, and then after we do the improv, it generates great discussion. So we do the improv, and then we pause after the improv, and we talk to the audience. We get a lot of audience feedback, and the nice thing about the audience is it's usually a mix of people. So it's not just nurses. We've had administration, we've had housekeeping, we've had a whole group of people. So it's nice that everybody is there to share their point of view, and there's a lot of sharing amongst the audience. There's a lot of talking, and there's a lot of discovery. There's a lot of aha moments, like I never knew that. I didn't realize that you were supposed to do that. And so they generate a lot of conversation. This is a picture here of one of our big improvs we did when we had a coach visit, and we actually had senior administrators sitting beside housekeepers having conversation. We had directors there, pharmacists. We had people from education, QI, managers, everybody. So we targeted everybody. It was really great. And we did get quite a bit of volunteers for this improv, and you just ask the questions. Does anybody want to do improv? They don't really know what it is, but you know, it's amazing. People actually step forward and do it, and they have a lot of fun. So while we get the feedback, we write things that we saw that was good during the improv, and they identify things that were not so good. So we identify a lot of issues that we have, and we found that the issues aren't, usually when we go around from place to place, the same issues seem to be popping up in all the areas. And we've identified a lot of those. And then we do ask them if they think they have any solutions. How do you think we can get around this? What do you think we can do differently? And see if we can get some people to give forth some solutions. We usually use an audience participation feedback form. The first time we did an improv, we forgot to use one. The second time we got them filled out, but we forgot to collect them. So now we're pretty good. We make sure that they're filled out, we collect them, and then if there's any really good ideas or if people have written their name down, then we have something to follow up on after. One of the things we've used consistently with our improv, as you can see in the left-hand side, one of our improv actors there has blue paint on her hand, and what we've used that is to make the invisible visible. So we use that as our superbug, and when we get the people to touch things and they see the blue paint going everywhere, they can actually see the transfer of the superbugs being spread around. And this visual has really been a great impact. We've had a lot of people say, people that are non-medical even saying, I had no idea that it was spread so easy and that it actually can happen like that. And then we've also had some people say after that they're going to take improv and use it for different things. We had someone say they were going to use it with their ski patrol group when they meet in the fall and talk about infection and stuff, that they're going to do some improv and use the blue paint. So people do like it. It is catchy. And like I say, every time we go, we get good participation. We get a lot of feedback, and people seem to have a lot of fun. One of the other things that we've done with our positive deviance is we've done some social network mapping. This was at the very, very beginning when we were just starting our project and trying to decide who we were working with, who knew about positive deviance, who should know about positive deviance, who we were going to get involved. And this is, we were doing this before we did a survey. We did a survey with about 150 people, and what we did is we surveyed everybody that was connected with 4-East that actually had patient contact or touched a patient. And we had a time period where we had to get the surveys done, and it was really challenging. We tried to get a 70% response rate, which we got, but instead of a couple of weeks, it took us a couple months. And what we found is that instead of just being in the computer, we had to find different ways. We had to actually make paper copies. We had to actually hunt people down. We had to give people different options to get the survey done because they didn't all have access to the computer. But what we did do once we got the maps finished is out east, they put these social network maps together. So then after we were able to bring people in that had filled out the survey to look at the map, and to find themselves on the map. And what we found when we looked at some of our maps, and it showed up, you can see it quite well when you see the map, is that all the groups, all the different disciplinary groups were very segregated and only kind of communicated with themselves. I don't know if you can see in the very middle of the map that's up on the screen now, the kind of green color is all nursing. They kind of all stuck together. The housekeeping group was all kind of stuck together. The food services group was stuck together. And then we found some groups that weren't even clustered together in their own little groups. They didn't even talk to each other. So we knew that we had to find some way to open up the communication, to get the communication going between the groups so we could find each other's issues out. And the nice thing about that was once we did the survey and we were actually able to bring the staff in and look at the maps, then they actually had some follow-through because they wondered if we were just going to make them fill out the survey and then have no follow-through. And we asked a lot of different questions, and we made a lot of different maps up, and we're still learning how to use the maps and what we're going to do with the maps. It's an ongoing process. When we had just before the summer, we had an open house, and we kind of opened it up hospital-wide. We didn't really know what kind of turnout we would have, but what we did is we set up a bunch of booths, we advertised it, we just had people drop in, and we just exposed them to the Positive Deviance project and what we were doing, and we had sign-up sheets for them to come if they wanted us to come to their unit and do any of the various activities. So this is, we had a hand washing booth set up here, and what we did is we had several boxes of gloves, and we had gone through some of the gloves and poked a few holes in them. We got them to wash their hands wearing the gloves with the blue paint and then take their gloves off and see how that the paint had actually gone through the hand, so that it's important to wash your hands, not just assume that wearing the gloves was enough protection. And we got a lot of aha moments at that station. We had senior management attend after the open house, and we were just updating them on what we were doing with our Positive Deviance project. And in this demo here, we did a fishbowl. So basically what it was is the core team in the middle talking about Positive Deviance, talking about what they had been doing over the last few months, how things were going, and the senior management sat around the outside observing and making notes, and then we talked for so long, and then we cut, and then we got them to share feedback and ask questions, and it was a different way to do a presentation, so it was a learning experience for us. This is a station at the open house that dealt with the Discovery Action Dialogue. So we told everybody about how we have these Discovery and Action Dialogues where we sit down with a group of people and ask them a series of questions and try and discover what their issues were, see if they could identify their issues, see if they could come up with some solutions for the ideas. And what we noticed on 4 East when we had some Discovery and Action Dialogues is that there was a general misuse of the yellow isolation gowns. We had several staff wearing them because they were cold, so wearing them out of context, wearing them around the nursing unit. We found that in general the nurses were using them improperly in the isolation rooms. They were gowning and gloving the patients to come out of the room instead of just putting clean patient gowns on them and having them wash their hands. And that not everybody going into the isolation rooms was wearing them when they were supposed to. So what we did is we did a photo campaign. We took a bunch of pictures of what you do and don't do with a yellow gown. We had pictures of nurses wearing them at the nursing station. We put big X's through them. We had pictures of house cleaning in the room wearing them properly and put big check marks. And we did a whole series of photos, and we put it up on a board. And we just talked a lot about getting comfortable with saying when you see a fellow staff wearing the gown out of the room that, can you please not wear it? It sends the wrong message to patients, to families, to other staff. And we really worked on this yellow gown campaign. And, excuse me. It's been quite successful. I've noticed lately that the yellow gowns are being used properly. We no longer have nurses wearing them in the nursing station, and I haven't seen a patient out of the isolation room geared up properly for a long time. So I think it's been quite effective. So that's one of our little success stories. Our coach was there, and he did a presentation on the culture change and talked about the surveys. We did a slideshow on our improv, which was quite fun, and just talked to people about improv, had people sign up if they wanted us to come to their unit and do an improv, and we've had several people sign up, so we've got lots of places to go come this fall. We had all the social network maps out on a board, and that generated a whole lot of conversation. And this is just a copy of the Discovery and Action Dialogue questions that we use when we have our little sessions and ask our questions. Another discovery I want to talk about is when we had a Discovery and Action Dialogue session, it was just an impromptu session. It was just on the unit, and this is it. We had it in our clean service room, so I gathered staff around. It's all nursing staff except in the kind of blue flowered uniform with a housekeeper. I'm running the session. I'm in green, and then Jackie's got her back to us. There's a piece of paper in front of her. She's a recorder, and she's actually recording what's going on and trying to, you call it catching butterflies. You try and catch little things that people say or little ideas. We're kind of looking for the positive deviance, the person that somehow got the right ID and is doing the right thing. And what we found here, we had a discussion about the isolation rooms, and the nurses were saying, you know, that if a sign's up, the sign's up. It doesn't really matter if the sign's right. We'll know it's on isolation, and that should be good enough. And what our housekeeper said, which a lot of the nurses, you know, had a big aha moment, is that if the right isolation sign isn't up, I don't do the right clean, and then I have to go down and redo that clean again. And she said the only reason I know the right sign's up is because I check in the morning before I do my rounds and make sure that the people that are in isolation indeed have the right signs up. So she's a little bit of a positive deviant, but a lot of our housekeepers are maybe comfortable and don't check in. So for the nurses that heard that there was a big aha, like, okay, I better make ssure I have the right sign up because A, it needs to be cleaned properly, and B, it's unfair to housekeeping to make them do their work twice. So you find out a lot of things in these impromptu discoveries. So our big goal is to find that positive deviant, to find the person that's already got the behavior that's doing something right, that's doing something different, and we sometimes find that a challenge, but it's ongoing. We're still working towards that. Just a picture of us at some of our conference, when we went to our conference in Toronto this June. And one of the things I wanted to say is one of the barriers we had at the very beginning of our project is we wanted to do active surveillance. So we wanted to, on our unit, swab everybody that came in and then swab them when they're left. Just try and catch anybody that picked up MRSA while they were on the unit. And the reason we wanted to do that is because we wanted to have numbers and we wanted to be able to provide those to the staff on the unit so that they could have a visual and have the numbers and have concrete evidence in front of them that, you know, this month this many people got MRSA on 4 East. But we came up against a barrier. We weren't able to have active surveillance. There was a lot of change going on in our lab. There was a lot of budget issues. They couldn't afford it. And, you know, we tried with our coach visit trying to talk to the head of the lab, trying to get it done. And we just hit a barrier. We couldn't get it done. But when we were in Toronto, we did a WISE crowd. It's kind of a, I don't know, what do you call it? It's an exercise you go through. So what you do is you identify a problem to the group at the table you're sitting at. So I identified this barrier that we couldn't do active surveillance. And so I talk about the problem for 2 minutes, and then what happens is the group asks you questions for 2 minutes, and then you turn your back around to the group, and for 7 minutes they discuss your problem while you listen in and take notes. And then you join the group and you have a discussion, and what came out of that is, okay, it's a barrier, it's not going to happen, so what else can you do to make those numbers visible to your staff? So what we came up with, we borrowed from another hospital that's already doing it, and starting in September, we're going to do what's called a safety cross. So we're going to set up a quality board, and we're going to set up a safety cross, which for every month, it'll have the days of the month from 1 to 30 or 31 or whatever. And every day that we go by where there's not an infection, we'll color it green. If we hit a day where we have an infection, we'll color it in red. And at the same time, we've mapped out our unit according to the room numbers, and what we'll do is if that day there's an infection, we'll put a dot in the room so that if in 2 or 3 days you have 2 or 3 infections come up, you put the dots on the rooms. You can have a little safety huddle around the quality board and say, okay, we've had 3 infections pop up, look at they're all clustered together in this area. Can we get on the problem, try and figure out what's happening, and solve the problem? So I think if we get the staff involved in this and get them kind of taking it over, this is a way to get over that barrier, and this is one of the things we're going to try. This is just our poster we've made up of what we're doing with the Canadian PD project. We're going to circulate it around our hospital, just hopefully it will generate conversation and just keep people up to date that we're here and this is what we're doing and we're there as a, you know, if they want to use us. While we were in Toronto for our coach, we made an actual hand-washing dance video for him. It was a lot of fun. It's just a way we keep ourselves having fun and moving forward and doing things as a core team. We had shirts made up. You can't see the back of them, but they have this giant picture of a lime green bug. And what we're going to do at any of our future Positive Deviance events is we're going to wear these shirts so that we're visible and we're bright. It'll generate conversation. It says on the front left side of the shirt, are you a positive deviant? And hopefully people will come up and say, what are you wearing that shirt? What, tell us about this. And it's just another fun thing we've done. The biggest thing is the culture change, and that's kind of what we're having sometimes a barrier with. People are so used to being told what to do and how to solve the problems. It's a real culture change for getting them to identify, come up with a way to fix it, and then go forward with that problem. So that's we're working with that. We have a lot of people that have come up with good ideas and volunteers good ideas. We're still working on getting them to feel like they have permission to go forth and put their idea forward and work on solving that problem. And that's about it. We don't want to say the end because we're not done. We've still got a lot of work to do. We've got some things planned in September. We're trying to set up a meeting with our volunteers. The volunteers do a lot of visiting of patients on admission, and we were hoping that we could have a discussion with them about hand washing, and that everybody they visit, they could hand out a hand washing pamphlet too. And we also thought we'd have an open house, not for the staff, but this time for visitors and patients, and do it in the front lobby and have some stuff with positive deviance, hand washing, isolation techniques, and what else we think we need. So that's what we've been up to. Take a breath. Take a breath. No, breathe. Use it on me. That's it. Katie? Anybody there?
So thanks a lot, Sherry. That was really awesome. I don't know if all of you can tell from out there, but from the start of the project to where they are now, that's an incredible amount of work. This is a very, very, very front-line process. It's throwing things right into the hands of the people at the front line for change. She's talked about some tricks of the trade that we use, such as discovery and action dialogue, how to improve conversations and communication in the front line. And by using improvisations, we work out problems by role-playing. So that's just an absolutely awesome presentation. I'm going to jump right into now Vancouver General and Melissa, and then we'll go into some question and answer at the end. So here you go, Mel. I'm going to just pass the ball to you in just a second. There you go. You should have the ball now, and you can advance your slides when you need to.
Okay, great. So my name is Melissa. I'm a patient care coordinator at Vancouver General Hospital. And Vancouver General Hospital is the main hospital in Vancouver, the Lower Mainland. It's a 955-bed tertiary care facility. And the unit I work on is called subacute medicine, which is a 56-bed unit. It's actually comprised of 2 units, 28 beds each. And our average patient age is about 75, and our length of stay is about 25 days. So our core team for the Positive Deviance Project consists of myself. We have an infection control nurse, Gail, Katie Coates, who's hosting, and we have 2 doctors on, Dr. Tucker and Dr. Chung. So our goal has been making the invisible visible. So on our unit, we've traditionally had a high rate of MRSA, VRE, and C. diff. The population we have is older. A lot of them are on antibiotics for long term, and so they seem to get C. diff more readily than other areas. But I don't think we haven't been doing as much as we should to help lower those rates. And so the PD project was a great way to make staff aware, take ownership of the issue, and really getting involved. And we actually just had a meeting the other day, and we just talked a little bit about how their journey has been from the start of the project to now. And one of the things that came up was they now feel informed. They actually know more. It's not so foreign to them. And so you can see that now on the unit, the culture has really started to shift. People are aware. People are willing to say to each other, give each other reminders, hey, you didn't wash your hands, this is an isolation room. Do you need help getting a gown and gloves on? So they are much more aware than they were in the beginning. And this is just a group of nurses on our unit, and they've got the blue paint on, or purple paint, which we use to help make things visible. Because as you know, MRSA, viri, C. diff, all those bugs, you can't see them. But when you actually do improvs or different demos, having that visualization is great to see the spread. So this is our Positive Deviance board, which has updates for the staff, and we do discovery action dialogues. We have them twice a month, and it's a time when staff who are on that day get together and they talk about feelings that they have around the spread and things that they can be doing to help decrease that. So something that came up a lot was clutter. Clutter in the halls, clutter in the bathrooms, clutter everywhere. We are in an older building, so that's always been a huge issue, and not being able to clean properly. And so one of the things they felt really strongly was to have the bathroom organized. And so what they've done is they labeled everything, so everything has a place now. So that's one of the initiatives they had there. Another one was patients sanitizing their hands prior to meals. As you know, we all wash our hands before meals, but what about the patients? Usually we're rushed, we give them a tray, and we forget about that step. And so this is one of the signs one of the OT aides made up, and it's plastered all over our unit. And we also have a lunch group, which our OT aides lead, and what the protocol is before they eat, they all get a squirt of microsan. And so now that's the norm. They wait for that before they eat. And so it's something that we are continuing to do with all of our patients, is ensuring that their hands do get clean prior to meals. So we did an improv. We've only done one, and our production crew is called Bugging Out and Boogie Down Productions. And so we ran it on one of our units, and just the staff that were there, plus we invited other areas to come and participate. And we had, there was 4 scenes, and it was just sort of the highlights that staff found they saw a lot. So one was, family members going into the fridge and having gowns and gloves on, and that's one of the issues that we really, really struggled with a lot in the beginning of the project, and it's actually something that you don't see anymore, which is absolutely wonderful. Another one was the blood pressure machine that goes from patient to patient, and does it always get wiped down in between? And when we bring them out of those isolation rooms, should we be using them, or should everybody have their own blood pressure cup? So those were the issues that came up in the dialogues that came around it. And people found that at first they were quite hesitant with the whole idea of the improv, not sure, what that meant and what their involvement or their role was in there. And now it's something that they think is absolutely great. We had a PD open house, and we just put out a whole bunch of brochures, and we advertised it throughout the hospital through our patient care coordinator meetings. We sent it out to all the different disciplines and invited everybody, as well as just people just walked in and participated. And so this is our hand hygiene station. So we had one lady who manned that, and she did the glove demo, where some of the gloves have holes in them, and you put some paint on their gloves. They simulate washing their hands, and when they take the gloves off, sometimes there's spots of paint there, and that's sort of an idea that, you really need to clean your hands before and after glove use, just to ensure that you're not transmitting. We had a discovery action dialogue station where our infection control nurse talked a little bit about the process of using discovery action dialogues and what that meant. A really interesting thing, I don't know if you can see in the corners, we had a floor map, and we had an outbreak of C. diff, and we had been doing really, really well throughout the project, none of these outbreaks, and then we have this cluster of CDF. And this was the first time staff actually took away the idea of, okay, what are we doing wrong? Like, what happened here? What can we do better? And they really were able to reflect and came back and they were like, okay, what are the things we're doing? We're washing our hands, but how else is it being transmitted? And they took it to that deeper level, which was really interesting. They actually took ownership of this issue and came up with solutions and what they were going to do, which has been absolutely wonderful. We had an improv station where we just talked a little bit about the use of improv and how we used it. And hopefully we'll do a little bit more. We're not as comfortable with it as Kelowna seems to be. They've done great stuff with improv, but we're working on it there. And then culture survey. So throughout the Positive Deviance project, there is a survey that goes out to the people who are in contact with our unit. And through the results, we had some data. And so people were able to sort of read the questions of the culture survey and put down some ideas with how we as a community, like a hospital community, could do things differently and better. And our social network maps, which seemed to really be the star of the whole open house. People were really interested in seeing where their name fit in the community and what links were joined to their name. And I'll show you a bigger one. So, for example, who have you worked with to eliminate superbugs? So they would find their name and see, okay, who are my connections? Where am I lacking? Who could I create connections with? And people were also able to write down comments. And so one of the comments was, doctors are at the edge of things. So, you know, your initial thought would be that the doctors would be more involved in eliminating superbugs and have be more of a hub, whereas they're more on the periphery. And Sue Scarf, who's one of the infection control leads, she's in the middle and she's got a lot of connections around her. However, those connections aren't really attached to the other core that's happening on the opposite side. And Eva, who's one of our housekeepers, and Lisa, who's one of our LPNs, really seem to have a lot of connections there. And how do we draw them? How do we draw other people into forming a more cohesive group? Another map that we had up was, who would you like to work with in the future to prevent superbugs? And so people were able just to say who was missing in the surveys, who else needed to be there in order to make elimination more effective. And new ideas. So who did you go to with those new ideas? And it says, you know, physicians need to be more involved. They seem to have their own hub, so they go to each other, but they don't go to the other group. And awareness informing patients about the importance of hand hygiene. So people just sort of put out what their ideas were in going forward. And then who do you talk to about superbugs? So that was another one that was really quite interesting. And as you see, there's one main hub and then this little group of people on the edge. So one of the comments was, why is it so spread out? And what about this disconnect? So how have we grown? So PD has really helped our unit and our staff with self-reflection. So as I said earlier, they were able to really reflect on what are we doing now, how can we do better, and how do we get more people involved. And so working as a team, now you see staff really coming together to come up with solutions, which is absolutely great. Challenges. So we've been really struggling with expanding the core team to include more disciplines. So getting our physios involved, our OTs involved, phlebotomy involved, technicians, porters, so getting all those groups involved. Sustaining positive deviance, so making sure it has such a strong foundation that if someone in the core team goes, it's still it's still very alive and very prominent in our hospital. And then ensuring that it continues to be supported financially so those changes can be met. So our future plans is a safety calendar. We call it our bug tracker. So there's just a picture of it there. And what we have is on the top, there's the month. And so all the green are infection-free months, and the red are infection-free days, and the red are the days that we've acquired an infection. And then on the bottom there is a floor map, so you can see what unit, what room the infection was acquired in. And so you can see links to, is it environmental, is there proximity, what could be causing it. And it's really created a lot of dialogue with the staff. They tend to go to it and go, oh, yeah, we're doing really good, or, oh, what happened here? Which room is that in? Oh, is that the room that someone else got it in before? What are we doing? So it's really been great for people to really start talking more and at a deeper level. We're spreading it to other units. So right now we are spreading it to one of our other units in the tower, with thoracic and respiratory units, and really trying to get it, other units really taking on the PD way. We're partnering with the Literacy Embedding Group. They are a group of people who are at our hospital currently to look at housekeeping and literacy, and whether things are communicated in a way that everybody can understand. So that's been really great, and giving them ideas in terms of how have we been using PD to get our housekeepers involved. Job shadowing is something else we're doing to help really create connections, and creating what they call twosies is when you see in the network map two people who are joined, how do you get two people who are joined, how do you get them further involved in the PD? And so we're getting groups like keeping and health and PCA's involved, and porters with RNs and doctors with phlebotomy. So we're really trying to do that and presenting our data. So there's some opportunities for us to present our data to other groups. And so that's the end of the presentation. Any questions?
That's perfect, Mel. Thanks so much. And as you said, are there any questions that anybody has of either team or any of us actually about positive deviance or data, anything you like?
Hi, it's Nikki from Kelowna.
Hi, Nikki.
Can you hear me?
Yes.
They mentioned, the Vancouver group mentioned that you needed to be financially supported. And so my question is, what kind of financial support is there for the Positive Deviance project?
So currently for us, we have just for the things that we've been doing, we've really been trying to use the resources we have on the unit. So going to our manager and asking for funding to do different things. And we've really tried to keep it really minimal. But there's, when things need to be changed, we are in an older building where things aren't ideal. It would be really nice to have a little bit more backing so that things can be created to adapt to better patient flow.
The one thing with this process that I will say, it's Katie again, is that you really need to have your senior leadership support, because this is such a frontline approach. Your resources are actually very minimal. There's not a lot of huge costs involved in this, but there might be some. The managers may be asked to remove the bigger boulders and help with maybe some basic redesign, like maybe installing some shelving units, that type of thing. But your leadership support is the biggest thing I find with Positive Deviance. They have to allow you the room to grow and be creative, and they have to back off. They're only there for the frontline workers to ask to remove the bigger things that they can't do themselves.
Sherry from Kelowna, the one thing we found is that we just assumed that there was no money and that if we wanted to do things, we couldn't get them done. And once we started asking, even for little things like we want to get some T-shirts made, we want to make this poster, we want to do these things, and we asked different managers from our core group, and we were covered. So, you know, you don't know till you ask, so don't assume they're not going to help you out.
Oh, that's a good point, Sherry. Thank you. I think that's probably one of the biggest struggles when we look at something like positive deviance is involving the leadership. And certainly in the Kelowna improvs where you did target leadership to come in and participate, I think that's an excellent strategy to get that kind of support. So thank you.
I think the one thing that I found with the PD approach is that when you do your kickoff, if you can include as many people across the disciplines as you can, including SLT, to be involved right from the get-go, one that probably builds you a good core team and gets your support right off the bat.
That's so true, Katie, because I think with our kickoff it was really small. And so really now trying to backpedal a little bit and get we've had some changeover with senior leaders, but getting those people involved has been a little bit more of a struggle.
I also found, it's Missy from Kelowna, that talking even after the fact, you know, like we'll be doing a presentation to our infection control group about the workshop in Toronto, and then just showing some administrative people, you know, like this presentation, or Holly on our core team just showed us the booklet that's out from this organization. And it mentions Kelowna General being part of this, and you know the www.positivedeviance.ca website. There's pictures from that show that we're involved in all of that, and any little bit of exposure is good to show administration.
Yeah. And I think that too, over the last 6 months at least, our ability to present has been huge. There's huge interest out there in what positive deviance can do, because really the traditional approach of top-down doesn't work for most things. It does for your technical things, like, you know, this is the product that you're going to be using from now on because it's cheaper and better, blah, blah. But for some of these big change initiatives, it doesn't work. And on that note, I'm just going to put a plug in for the Safer Healthcare Now. They've got the second wave of their national NAC project. So that is the new approach to controlling superbugs. They're starting to register their second wave. It's going to start in September. So if any of your teams out there or folks out there want to get involved in the positive deviance approach, then look to the Safer Healthcare Now website, into the NAC's registration, and get on, because we've just had our first information call this morning for the Safer Healthcare Now project. Any more questions or comments?
Hi. Question there from Nadine.
Hi, thank you. Nadine Glenn from Grand Prairie. What great presentations. I've really enjoyed hearing about positive deviance. I'm very much a beginner in learning about this, and I'm most excited about the use of improv as a way to share information and learn information. How do you've left me wanting, you've whet my appetite. I want more. How do I get more information about positive deviance workshops? I'm going to buy the book that was suggested at the beginning. So thank you so much for giving so much great information today.
You're so welcome. I'm just going to put in the chat here the books. There is The Power of Positive Deviance. There was Orbiting the Giant Hairball. And we'll put the link up for you, and the recording will be available on the BCPSQC website for you after the fact, so it will be there.
Excellent. Thank you very much.
Hi. It's Dale Marshall from Fort McMurray, Alberta.
Hi.
I echo Nadine's comments. The question I have is the Vancouver presentation on the hand washing regarding MRSA and C. diff. I know the presentation speaks for itself, but do you have any evidence that those rates actually decreased, or is it too soon to tell?
So our hand hygiene compliance has gone up to 85%, which is the highest that our unit's ever had. So we're quite happy with that. And so for C. diff, on average, we're close to this. We're a little bit better than we were, except for the outbreak that we did have. And our rate for VRE and MRSA have actually gone down slightly. But we still have a ways to go.
Thank you.
Okay, just realizing that we've come to the hour. It's now 1 o'clock. Like I said, I've just posted on the chat the books, the positivedeviance.ca, positivedeviance.org website. The recording will be available on our website for you in the next few days. And please feel free to check out our website for further virtual learning opportunities to come in the future. We're trying to get some really unique topics for you. And again, please fill out the survey when you sign off today, because we'd love to hear from you what you would like to hear about for future virtual learning sessions. So thank you in particular to our two teams, from Missy to Sherry to Melissa, and all of you for joining us today. Thank you so much.
Thanks, Katie.
Thank you. Bye-bye.